Function of the immune system. Normally, antibodies are supposed to attack foreign antigens that can harm the body. In MG patients, their antibodies attack receptor sites on the postsynaptic neuromuscular junction, and the body cannot replace them fast enough. Therefore, acetylcholine is released, but then does not attach to the receptors. Without these receptor sites being activated, the muscle can't contract the way it's supposed to, and this causes muscle weakness. There are different ways in which MG can initially manifest. Commonly, patients will demonstrate eye muscle weakness, which is also called ptosis, which is drooping of the eyelids, diplopia, which is double vision, and also they present with limb weakness or bulbar weakness. In 15% of patients, bulbar muscle weakness will be the first presenting symptom of MG. As the medical SLP, it's our role to accurately identify these symptoms as being characteristic of MG and ensure the patient is practicing safe swallowing and successful communication. As a part of the interdisciplinary team, it is our responsibility to also educate other team members about our findings in relation to communication and swallowing in our evaluations and appropriate steps that should be taken to manage the disease. Symptoms of MG were first described over 300 years ago in the literature, but the etiology of why and how these collection of symptoms were occurring was unknown. In 1672, clinician Sir Thomas Willis wrote a book that described a patient which was able to walk in the morning, but then by noon was unable to move his hand or foot. He also described a woman who spoke with ease in the morning, but then after speaking for a long time, or eagerly as he said, could no longer speak a word and became mute. He also noted that this woman could not restore her voice after an hour or two. Another physician, an English physician, his name was Wilkes, in 1877 described a patient experiencing classic symptoms of MG, just like the other clinician. This one was ocular muscle weakness and bulbar weakness, such as dysarthria and dysphagia, and the patient ended up dying of respiratory failure after the onset of her symptoms, which is common of MG. She also had no brain lesions. It was not until the early 1970s that researchers began to understand the neurophysiologic correlates of MG and develop effective diagnosis and treatment methods. The incidence rate has increased since the 1970s, from between 3 and 6 cases in every 1 million people per year to now 30 cases in 1 million people per year. There likely has not really been an increase in individuals with MG, but rather probably just a better understanding of the disease, which has allowed for better detection and diagnosis. Although we have an enhanced understanding of the disease process from when it was first described, there currently isn't a cure. Clinical presentations of MG remain the same, but are more widely understood by healthcare professionals, and therefore are detected and managed more effectively. The medical SLP plays a critical role in contributing to the assessment and diagnosis of MG, as well as in the management of the disease. Often, this management can be throughout the lifetime of an individual with MG, as it fluctuates between good days, then there's days of myasthenia crises where they have to go to the hospital. Acetylcholine to bind with receptors on the postsynaptic neuromuscular junction, allowing muscles to contract normally. When the motor neurons of the peripheral nervous system leave the spinal cord, following their nerve pathways to their respective muscles, their release of acetylcholine is not received properly on the postsynaptic junction due to alterations or absence of acetylcholine receptors. As a result of this, clinically, we often see muscle fatigue and weakness. One of the defining features of MG that differentiates it from other diseases is that muscle function is superior earlier in the day and markedly worse as the day progresses. Although in 2/3 of patients the dominant presenting complaint is diplopia or ptosis, in 15% of patients their initial symptom is difficulty chewing and swallowing or speaking. This is due to palatal weakness and results in incomplete closure of the velopharyngeal port. Patients also will experience fatigue when chewing and weakness of the orbicularis oris muscle, resulting in anterior leakage. One also might hear of the myasthenic snarl, which looks like somebody's always frowning, but it's really because that orbicularis oris muscle is weak. It looks like that they're frowning. Other oral stage difficulties will include lingual weakness resulting in decreased posterior transfer of the bolus and the movement of the back of the tongue meeting the posterior pharyngeal wall. As the bolus continues past the oral stage, weakness of pharyngeal muscles leaves residue in various areas. And again, this is due to pharyngeal muscle weakness. Also, there's the risk of aspiration, which is the main concern, and this is because of, again, these reduced muscle strength, and the true and false vocal folds can't completely adduct, so fluid and liquids are susceptible to passing that. With all of the muscles involved in swallowing being fatigued, the structures no longer perform their proper function, and the entire process is compromised. And this is where you see the importance of the interdisciplinary team. This is why it's crucial for the SLP to work closely with the neurologist. As soon as MG is diagnosed, the SLP needs a consult. Early identification of dysphagia is critical to preventing silent aspiration, which can lead to aspiration pneumonia. And particularly for the myasthenic patient, pneumonia is even more dangerous because of their already compromised immune system and respiratory function. Preserving this function will help them rebound from further myasthenic crises that may occur in the future. When asked to answer the referral question of diagnosis, an oral peripheral exam is critical to assess facial weakness and cranial nerve damage, particularly of cranial nerves 5, 7, 9, 10, 11, and 12 because of their relations to bulbar muscles. And the assessment of these nerves are actually critical to the diagnosis of myasthenia gravis. An important measure is also requiring the patient to do repetitive tasks involving lingual movements and speaking. This will demonstrate their level of fatigue over time and contribute valuable info to differential diagnosis. So for instance, the SLP would ask them to press their tongue against a tongue depressor, ask them to do diadokinetic exercises such as padaka, and see if they fatigue over time. And that is a key feature of MG. Allow the patient to lead as normal of a life and as comfortable as possible. For instance, if a person truly enjoys a certain kind of food that's difficult to chew, like steak, which can make the patient fatigue while chewing, we would try and help them devise methods to help safely consume them. If we suggest that they eat that food during a time where they're at the peak of their medication, and this would help them to chew it efficiently and not fatigue, we would try and do this if that was possible. Sometimes MG patients have flare-ups of their disease and go into myasthenic crisis. During this time, we may be consulted to assess their current swallowing function and ensure that they're not aspirating. We can monitor their status during myasthenic crisis and alter their diet depending on their medical status at the time. They may have to temporarily tube feed, and we would help make this decision, as well as work to wean them off of it, or whether it be modifying their diet. Maybe they can only have thin liquids, maybe they can only have soft things. We might suggest things such as allowing the patient to rest before eating and drinking, providing foods that are, like I said, soft, tender, not sticky, so it's not causing that residue, telling them to have small bites or to chew it well, things of that nature. We also would educate and counsel the patient and the family, as well as the other team members, about dangers of silent aspiration and precautions and strategies like the ones I mentioned, just to optimize the comfort and the safety of the patient. And ultimately, in acute care, we're focusing on the swallowing and, like I said, the safety and not aspirating. So communication probably would not be as grave in the medical setting, so that wouldn't be the first thing that we would work on. That would probably be something for outpatient rehab. Also, it's important to think of the role of medication for assessment and treatment of the MG patient, because they're very dependent on cholinesterase inhibitor medication, and when assessing and treating, it's really important that we do assessment during the time that they're on this medication or at the peak of this medication, so that we're not having them aspirate on foods or making sure that they're safely swallowing things. In addition to just safely swallowing, it's also so that they don't fatigue while they're chewing or while we're assessing or while we're treating, and they can perform at their optimal level. With muscle fatigue and weakness, most commonly in the ocular muscles, but also in the limbs and bulbar muscles, as I mentioned. They're in 15% of patients as the presenting symptom. In acute care, assessment and diagnosis is critical to ensuring the patient's symptoms are managed appropriately and that we prevent further myasthenic crises. The SLP in acute care focuses on the assessment and diagnosis of MG in relation to speech and swallowing mechanisms and manages symptoms to ensure safe swallowing. Our contribution to the interdisciplinary team is imperative for diagnosis and management. We have to contribute our piece to the puzzle and see if it matches with what other people on the team see, and all of us need to collaborate to give the best care for the patient. Although there is no cure, it's one of the most well understood autoimmune diseases. We know the causes, we know the mechanism, the physiology of what happens, and therefore MG patients are living longer than they used to and more comfortable lives than they previously have, just because of that understanding, and we know how we can modulate their symptoms and flare-ups.